Alright, so we're going to continue reading our first aid for step 2 CK, and we left it off last time by completing hyperkalemia. So now we're just going to continue hypokalemia, and this is a very important part that we are covering currently, the whole part of electrolyte disorders. This is very high yield and it's very easy, very simple. You just have to follow along and just have to memorize what I tell you to memorize and understand what I tell you to understand, and you're just going to get a good grip on it. So just follow me along and we will complete it together. Right, so hypokalemia. Serum potassium less than 3.6 milliequivalent per liter. Etiologies are as follows. Transcellular shifts, insulin, beta agonist, and alkalosis all cause insulin, beta agonist, alkalosis all cause potassium to shift intracellularly, right? GI causes diarrhea, chronic laxative abuse, vomiting, nasogastric tube suction. These are the GI causes, right? So, main thing in all of these electrolyte disorders is to know the cause. The cause are very important. You need to know the cause. All of these are very, very important. So you need to remember, you need to know them, right? Insulin causes potassium to shift intracellularly, and you can understand this by insulin powers. Basically, if insulin is increased in the body, then the body is in a fed state, in a high energy state. When the body is in a high energy state, what happens is that the body creates more ATP. When the body creates more ATP, if ATP is going to increase, then what is going to happen is that the ATP sodium potassium pump is going to increase. So when the pump increases, what happens is that the potassium ions they go intracellularly. That's what happens. So that's why insulin is a cause. Beta 2 agonist, again, beta 2 agonist increase the activity of the sodium potassium pump. So beta 2, you can remember that they increase the activity of the sodium potassium pump, which again in turn leads to more potassium getting transported inside the cells. Alkalosis also causes potassium to shift intracellularly. How does that happen? Let's see. Right, so ran into a bit of a problem now, but we're back. So we were discussing that how these different causes cause hypokalemia, right? So insulin, we already know, beta 2 agonist, we know, and now alkalosis. Alkalosis, how does alkalosis cause hypokalemia? There's a simple mechanism for it. So what happens is that this is the this is the rule, right? So decrease in protons is going to lead to decrease in potassium, and increase in protons is going to lead to an increase in potassium. So this is a basic rule, right? So this is basically what happens. Now what happens is that imagine that there is a cell with a nucleus, right? This is your cell, and this is your hydrogen potassium pump. Now, what is this pump? So, basically, what happens is that most cells in our body, or cells that are of in muscles and the kidney, they actually have a hydrogen potassium pump. But most cells do. Mostly, these have it on their membrane. So, what the function of this pump is to maintain electrical neutrality. So, what happens in times of need? this pump can either take in or push out hydrogen ion. And in doing that, uh, it has to take in or push out the other thing. So if something, it's one of the things going in, the other has to come out, right? That's what happens. So this is an antiporter. So what happens in when there is decreased hydrogen in the blood? So what happens is this pump increases the excretion of hydrogen to maintain electrical neutrality, and in turn takes potassium, right? So what happens is if this is your plasma, so potassium ions get taken in, and this gives rise to hypokalemia. So this gives rise to hypokalemia. The opposite of this happens when there is an increase in hydrogen. So what happens is if you imagine the cell again, this is your pump, this is your nucleus. So if there is increased hydrogen, what happens is this gets taken in to the cell to bring down the level of hydrogen outside. And in turn, it pushes out potassium. So it increases its value. So this is the mechanism. And this relationship is important for you to remember. This is very important. So acidosis gives rise to hyperkalemia. Alkalosis gives rise to hypokalemia. I hope this is clear. It's a very important mechanism to understand. Right, so all of this cause potassium to shift intracellularly, and the other cause, this you have to remember, and the other cause is the GI losses. GI losses are also important to remember. Diarrhea, chronic laxative abuse, vomiting, nasogastric tube, suction. So in all of this, the easy way to understand is in all of this, there is a loss of water, right? So the loss of water would in turn activate the RAS system, and the RAS system would excrete out potassium. Aldosterone specifically would excrete out potassium. So this is how this cycle works. Also, something else you need to understand is that stool is rich in both potassium and bicarbonate. So you need to understand that how chronic laxative abuse, diarrhea, all of this would lead to hypokalemia. Vomiting and nasogastric tube, of course, you can understand that they are causing loss of water from the body, and that would then, in turn, activate the RAS system, which would then excrete out more potassium. So this is exactly what is written in the diagram. So what caused the potassium to shift in are these three by the mechanism that we've already understood. And what causes the potassium to shift out, such as hyperkalemia? So what causes it? Cell lysis causes it. Acidosis causes it. Exercise causes potassium to shift out. And hyperosmolarity. So we've already discussed this in the previous video, but it's good to revise things. Now we have three questions here. 26-year-old woman with a history of depression presents to the emergency department with altered mental status, tinnitus, nausea, and vomiting. An ABG shows a pH of 7.4, pACAT of 22, and a bicarbonate of 13. What is the most likely diagnosis, and what is her acid-base disorder? This is a very easy question. I want you to solve it yourself, and we'll discuss this sometime later. A 37-year-old homeless man was found unconscious on a park bench. Upon waking, he complains of severe muscle soreness and red urine. His urine dipstick is positive for blood. What is the likely cause of this finding, and what is the best next step? This is a rhabdomyolysis situation, so I've given you another clue for this question. And for this question, I've given you a clue by highlighting these, so you need to focus on these. For this is an abdomyolysis situation, so you need to tell me what is the next best step. And question number three is a 29-year-old woman with a history of bipolar disorder presents to the emergency department with altered mental status. All exams, she has dry mucous membrane and decreased skin turgor with a blood pressure of 92 by 40, heart rate of 106 beats per minute. Her serum sodium level is 154. What is the next best step in management? So think about all of these. We've studied them and we'll discuss the answer in a bit. So now we're looking at how does the hypokalemia manifest itself on the ECG. So what they're basically showing is the U wave. U wave is an additional wave, so this is your T wave, right? So U wave is an additional wave after T wave. So this is a prominent U wave you can see here. This is a sign of hypokalemia. Key fact, if a patient is on digitalis, potassium levels must be carefully monitored. Hypokalemia sensitizes the heart to digitalis toxicity because potassium and digitalis compete for the same sites on the sodium potassium pump. This is very important to understand. And another key fact is that hypokalemia is not responding to potassium repletion. Check magnesium levels. So what basically they're trying to say is that if this is a cardio muscle cell and this is your sodium potassium pump, right? So this is a cardiac cell, right? So what happens is if the patient is taking digitalis or digoxin, so digoxin goes on this works on this potassium sodium potassium pump, right? So digitalis goes in and works there. So digitalis is primarily going to work on the sodium potassium pump. Now there are sites. Let's say if I am zooming this, I'm getting zoomed in on this pump, and this is the pump in its magnified state. So there are sites on it. One site holds the potassium, and one site holds the sodium. So the digitalis is going to attach to this site over here, right? And normally it can, because not all sites on the pump are filled with potassium. Normally it can attach to it. The presence of potassium basically keeps this in check. But if the potassium is low, then consider that tens of thousands of cells, cardiac cells that have this pump and have this site. Now this site is empty, right? Now this site is empty. So what happens is every cell is just going to accommodate digitalis, and this will lead to toxicity. This is toxicity, all right? It's toxicity. So this is how this basically works. You remember this, that hypokalemia can give rise to digoxin toxicity. And magnesium levels you have to keep in check if the hypokalemia is not responding to potassium repletion. So an easy mechanism of this, to understand this, we have to go back to our whiteboard and we have to clear this off. So what happens is renal tubular cells. So you know that there is a thick ascending loop of Henle, right? So there is a thick ascending loop. So what basically happens is that this loop is responsible for the reabsorption of potassium. So if this loop is responsible for the reabsorption of potassium, then uh, there is a this happens through a pump, right? This happens through a pump. This is the sodium potassium pump, right? Or uh, the NaK2Cl pump, right? Both of them reabsorb potassium. Both of them do. But magnesium is an important cofactor. Magnesium is an important cofactor for these pumps. So if there is going to be less magnesium, then these would not work properly, and there would be less reabsorption of potassium. So this is what you need to understand, that magnesium is an important cofactor. This is an important cofactor you need to keep in mind. So this is how you need to check magnesium levels. So if magnesium levels are low, it wouldn't matter how much potassium you give to the patient. The patient will not be able to reabsorb the potassium from the urine, and it's just going to go out, and potassium levels are just going to decrease. So this is how this works, right? Another cause of hypokalemia are renal losses. Diuretics, loop thiazide, uh, primary mineralocorticoid excess, hyperaldosteronism, these all are similar. Decreased circulating volume stimulates RAS and mineralocorticoid associated potassium secretion. Barter and Getterman syndromes, drugs, gentamicin, amphotericin, diabetic ketoacidosis, hypomagnesemia, type 1 and type 2 RTA. So we were looking at renal losses last time, and we read through those. But I would like to get into this more, right? Because either you remember this and commit them to memory just as they are, or one simple way to easily remember all of these causes is to understand how each one of them cause hypokalemia, right? But getting before getting into this, I'd like to get into the answers of the questions that we saw above. So the first question was the tinnitus one. So this patient had mental status change, tinnitus, nausea, and vomiting. Basically, they were asking that what is her acid-base disorder, and I gave you the clues that you're supposed to look at these only, right? So the answer to this question is basically this is a case of aspirin overdose, and though her pH is normal, she has a mixed metabolic acidosis and respiratory alkalosis. Her bicarb is low, indicating a metabolic acidosis, and Winter's formula predicts that her PaCO2 under normal compensation should be 29. Her PaCO2 is lower than this, it is 22, which indicates a concurrent respiratory alkalosis. Right, so this is the Winter's formula, right? 1.5 times the bicarb minus plus 8. That's what basically it is. So this would just be simply this would be simply be minus. So this is what the Winter formula is. So what you had to do in this question is basically just look at the pH, look at the bicarb. So bicarb is obviously low. Then use it to find the compensation of the PaCO2. So by Winter formula, you will know that if whether the PaCO2 given in the question is rightly compensated, or is it low, is it high. If it's high, it is acidosis. If it's low, it's alkalosis. just as in this example, it is low. The compensation should be 29, but it is 22, so it is low. That is why it is alkalosis, right? Because if there is a metabolic acidosis, you don't really know that what whether the PaCO2 given in the question is compensated or is there another respiratory problem, concurrent respiratory problem. So you don't really know that, right? And how will you be knowing that is using the Winter's formula. So this is important to know, and you must remember this. So the easy question, even if you don't know what aspirin overdose symptoms look like, but just for a quick revision, aspirin overdose commonly presents with synchronism. Uh, if you remember, I don't know if this is the right spelling, but it presents with synchronism. What synchronism is? The synchronism is basically mental status change, tinnitus, nausea, and vomiting. Maybe also headaches. So it presents with synchronism, right? Even if you don't care about the synchronism part, just remember that tinnitus, nausea, vomiting, and mental status change are important symptoms. All right. The patient probably has rhabdomyolysis. Right. This is what I told you that this is a clue. And the urine dipstick is detecting myoglobin. He should be managed with saline, hydration, mannitol, bicarb, and an ECG to rule out life-threatening hyperkalemia. So this was the case. I told you guys that what's happening. So basically, this positive for blood is actually myoglobin. So myoglobin and hemoglobin are not differentiated in urine dipsticks. So whether you have myoglobin or you have hemoglobin, both will be positive for blood. Although in reality, only hemoglobin should be, but both will be. So urine dipstick is not really a good measure for rhabdomyolysis. So you have to do urine analysis for it. But the case is quite similar. Case is quite easy. A homeless man, probably alcoholic, on a park bench. He complains of muscle soreness, which means there is rhabdomyolysis occurring, and myoglobin is in his urine. Myoglobin can give a characteristic red color. So, what is the likely cause of this finding? Rhabdomyolysis. So, I gave you the clue, right? Rhabdomyolysis is related to hyperkalemia. I think we studied this in the previous sections that rhabdomyolysis is associated with hyperkalemia. So, what is the next best step? You will do hydration and you will give uh, mannitol bicarb. Hydration is basically the single best answer. ECG should also be done to rule out any changes because hyperkalemia can give rise to ECG changes. So that is what you should look out for. All right. So the third question: 29-year-old woman with a history of bipolar, and she had decreased mucous membrane and skin turgor, BP of 92 by 40, heart rate of 106, and serum sodium of 154. What is the next best step? So hyponatremia. Patient probably has nephrogenic diabetes insipidus. From presumed lithium use, she is hypovolemic with unstable vital signs. Therefore, she should be treated with initially normal saline. So I told you guys whether it is hyponatremia or hypernatremia, normal saline is your best friend, right? This is the best answer in every case. And then switch to dextrose 5 once her volume status improves. So you can remember dextrose 5 also, but this is just going to be your best friend. Mostly, this is going to be the answer. So now we looked at the questions, and I think it's time to go forward with the renal losses. So it is important that you remember all of these causes: the renal losses, the transcellular shifts, and the GI losses. So both of these are already explained. Now this we must explain to you. So each reason, each etiology that is given here has a different mechanism. Some have overlapping mechanisms, but we're going to discuss all of them so that you must remember. So this is very important. Right? I'll put 2 stars. Right. So for this, I have some of my notes. Uh, so diuretics are the first. First are diuretics, loop and thiazide. So how do diuretics bring about the change? They basically increase urine production and flow, right? So basically there is less water. More water is going out of the body, less water is in the body. Loop diuretics specifically, they block the NKCC2 channel of the loop of Henle, and this prevents sodium reabsorption. So more sodium reaches the collecting duct. The collecting duct then reabsorbs this sodium and to maintain electrical balance secretes potassium into the urine. Thiazide diuretics, on the other hand, block the NCC channel in the distal convoluted tubule so that more sodium reaches the collecting duct. Also, by causing fluid loss, they trigger aldosterone release. Right. So basically, what is the basic phenomena is that there is decreased water in the body, and this gives rise to the RAS system, and this gives rise to decreased potassium. Right. So this is the first, and the second is that the specific mechanisms of both of the diuretics. So for loops, there is the blockage of the NK2C channel. So this gives rise to more sodium in the collecting tubule. This is the collecting tubule, and so this more sodium is getting exchanged for potassium, leading to decreased potassium. And for thiazides, there's the inhibition of NaCl channel. So it again it goes same mechanism, goes to our sodium. It gets increased sodium, and sodium while reaching the collecting tubule gets reabsorbed in exchange of potassium, and that is how they give rise. So these are the both of the mechanisms that give rise to hypokalemia as far as diuretics are concerned. So this is done, right? Now the saying primary melanocorticoid excess, right, or secondary hyperaldosteronism. So primary melanocorticoid excess, which is known as Conn syndrome, is a tumor in the adrenal gland that produces too much aldosterone. So aldosterone acts on the collecting duct to reabsorb sodium and actively secrete potassium. So this is basically, you know what aldosterone does. So this is basically excess of aldosterone. So this is excess of aldosterone, which leads to hypokalemia. So you know that, right? That's something difficult. Secondary hyperaldosteronism, any condition that reduces the blood flow to the kidneys. If it's heart failure, cirrhosis, renal artery stenosis, it activates the RAS system. This produces aldosterone to certain salt to retain salt and water. The side effect of aldosterone is potassium wasting in the urine. So again, you're increasing aldosterone. There are two ways to increase aldosterone. Either there is a primary way in which there is a tumor, or either there is a secondary way. That's it. Right. So easy enough. Decrease circulating volume. Again, this is also quite easy. It's the same thing. The RAS system will be activated, and potassium would be excreted out of the body. Barter and Gettleman syndrome, drugs. Now, these are a bit tricky. So, Bartter syndrome is a genetic defect that mimics a loop diuretic. The defect is in the NKCC2 channel, the loop of Henle. This leads to high sodium delivery and potassium excretion. So basically, this channel, there's a genetic fault in this channel. In this channel, there's a genetic fault in Bartter syndrome, genetic inhibition. So Bartter syndrome is equal to the loop diuretics. And the other, I think the Gittelman is equal to the thiazide diuretic. So the defect is in the NCC channel and distal convoluted tubule. This mechanism is identical to the thiazides. So the easy way to understand is, let me delete all of this, is that Gittelman syndrome is equal to the thiazide diuretics. And Bartter syndrome is equal to the loop diuretics. Let me fix this. Right. So thiazide diuretics, loop diuretics. They both have. So these are genetic defects. You don't really need to know any other detail about them, but these mimic, so causing hypokalemia in the end. How do drugs cause it? So gentamicin is basically nephrotoxic. The damaged kidney tubules cannot probably or properly reabsorb electrolytes, leading to a Fanconi-like syndrome where potassium, magnesium, and phosphate and glucose are all wasted in the urine. So gentamicin basically affects all of them. Potassium, magnesium, phosphate, and glucose. All of them are wasted. Amphotericin B, on the other hand, it binds to the tubular cell membranes and forms pores. These pores allow potassium to passively leak out of the tubular cells directly into the urine, like a hole in a pipe. So basically, if this is the uh, urine tube, proximal convoluted tube, and these are the tubular cells, these have potassium in them, right? This is blood, this is urine. So what happens is these have some tiny holes in them, right, through which potassium can get out into the urine, right, just like this. So this is caused by amphotericin, and gentamicin is basically generally nephrotoxic, so it affects the proximal lining and it results in the wasting of all of the all of the ions that are deabsorbed, such as potassium, magnesium, phosphate, glucose, all are wasted. Right, this is done. So diabetic ketoacidosis, again another cause. So diabetic ketoacidosis is basically it has multiple mechanisms. So osmotic diuresis is when very high blood sugar pulls water and electrolytes, including potassium, out into the urine. So that is the most simplest mechanism. Another mechanism is non-reabsorbable anions. So ketone bodies like beta hydroxybutyrate in the urine carry a negative charge. To balance this, the kidney excretes positive ions, primarily potassium. So this is a secondary mechanism. Third mechanism is obviously from osmotic diuresis, simulates aldosterone, and of course renal potassium secretion. And there's also a paradox that serum potassium at presentation is often normal or high because of acidosis shift. So in diabetic ketoacidosis, this you can remember any mechanism. Total body potassium is always low in diabetic ketoacidosis, but on labs acutely you can get normal potassium or even high because diabetic ketoacidosis is obviously an acidosis, so there is increase in hydrogen ion which leads to increase in potassium. So this mechanism we discussed earlier. But according to the reality, deacidosis is basically hypokalemia. So total body potassium is low always. That is a very important point. You need to keep that in mind. We also discussed this in the endocrinology lectures. But apparent potassium is always normal. So this is the apparent potential or the acute potassium or the potassium that is present on the labs, whatever you want to call it, right? And now it's hypomagnesemia in type 1 and 2 RTA. So hypomagnesemia is basically, we discussed it as a cofactor for the potassium secreting channel. That is how it doesn't work, right? But type 1 and 2 RTA, so basically type 1 RTA is a defect in inability to secrete hydrogen proton in the collecting duct. To maintain electrical neutrality when excreting other ions, the kidney increases its secretion of the next available cation, the potassium, which is positive. This leads to chronic potassium loss. This is in type 1 distal RTA. Distally, the proton is not getting excreted. In type 2 RTA, the proximal tubule fails to reabsorb bicarbonate. This bicarbonate floods the distal nephron and acts as a non-reabsorbable ion. So bicarb is negative, right? Its negative charge in the urine lumen pulls positive potassium out with it. This is similar to the ketone mechanism explained in the DKA, right? So this mechanism, non-reabsorbable ions. So let's get rid of this. So in type 1 RTA, which is the distal one, what happens is that they cannot reabsorb inability to secrete hydrogen ions. So there is increased hydrogen ions in the cells, right? So obviously there is the pump that we discussed, which is the hydrogen potassium pump, right? So if hydrogen is more inside, so now potassium has to leave, right, from the cells. So potassium has to leave because of this pump, and then because of this, potassium goes down. It goes into the urine and goes down. In type 2, what happens is that because of there's presence of so much bicarb in the urine, it has to be exchanged for potassium. So this is the reason. This is the reason, right? So now we've discussed all of the reasons why hypokalemia is caused, all of the renal related reasons, right? Now I hope that it is easier for you to understand, and I think this explanation would be sufficient. So history and physical examination presents with fatigue, obviously, muscle weakness, cramps, ileus, hyporeflexia, paresthesia, rhabdomyolysis, and ascending paralysis. Diagnosis: other workup that you must show, that you must remember to get is ECG, may show T wave flattening, U waves, and additional wave after the T wave, which we've seen this, and ST segment depression leading to AV block, subsequent cardiac arrest. So in potassium problems, you must really keep in mind the heart, right, the ECGs, and then is finally the treatment. Now the treatment is, we will read the treatment, but I think we will explain it a bit better from my notes. So what they are basically saying is you treat the underlying disorder and you give oral or IV potassium repletion. Oral is the preferred route for safety purposes. If IV is necessary, a continuous rate of potassium as an additive is preferred over an IV potassium bolus. Reserve IV boluses for symptomatic hypokalemia or ECG changes. Do not exceed 20 milliequivalents per liter per hour. Replace magnesium as this deficiency makes potassium repletion more difficult, right? So you give magnesium prophylactically. Now, to discuss this in detail, you obviously there is the treatment that you must give, but there's also this part of how to identify the etiology, right? So this part of how to identify what etiology is causing hypokalemia. So there is this uh, short algorithm that you must remember. First of all, how to see what is causing hypokalemia. So you have a patient presenting with hypokalemia. He has unexplained hypokalemia. So what you first do is you take the spot urine potassium, right? This is the first diagnostic test. So you take the spot urine potassium, and then you see if the urine potassium is less than 15 or if it's more than 15. If it's less than 15, then you must know that there are extra renal losses such as diarrhea, laxative, sweating. So then you go for stool studies and history. Why? Because obviously, if potassium is low in the urine, which means that the body is trying to save potassium from being wasted in urine because it is being wasted somewhere else. So that's what you need to keep in mind. If it's already being wasted somewhere else, so the body, the kidneys will try to conserve it in the urine. So if it's low in the urine, less than 15, it means that it is being conserved in the through the kidneys, and so you need to look at the other causes, extra renal causes such as diarrhea, laxatives, or sweating. If it's more, then of course there is renal wasting. So now you proceed to step two. Step two is you check spot urine chloride. So first you checked potassium, now you check chloride. If the urine potassium is high, you check urine chloride to assess volume status. Right, so basically you're checking chlorine to see because potassium is a positive ion. So chlorine excretion and potassium reabsorption are basically equal. So if potassium is going to be excreted, chlorine is supposed to be conserved, right? But basically, what you will get if you get low chloride, less than 10 millichlorians, then it is a chloride sensitive disorder, which means basically is that vomiting, diuretics, uh, all of these are causing the problem, right? Because there is less chlorine, so chlorine is also getting conserved. So potassium is also getting conserved. The potassium is getting wasted. It's high in the urine, but chlorine is getting conserved. So basically, this is a volume status problem, right? If chlorine is high, which means that this is a chlorine resistant uh, problem, which means that either the patient is taking diuretics actively, or there is hyperaldosteronism, or there is Bartter and Gittelman syndrome. So you must understand that the relationship of chlorine and potassium is such that if potassium is high, so normally chlorine should be low, right? So if potassium is high in the urine chlorine should be low. But in this case, if the urine chlorine is low, then we obviously say that that is, of course, a normal situation, or it is a chlorine sensitive situation, which means that again there is nothing wrong in the kidneys. There is obviously something wrong outside. But if it is a problem, if urine chlorine is also high, potassium is also high, and chlorine is also high, so then it is a chloride resistant etiology, which means that there is use of active diuretics or hyperaldosteronism or Bartter and Gittelman syndrome. Then you look at the blood pressure, right, and aldosterone ratio. So if both of these are high, potassium and chlorine, if both of them are high, then you look at hypertension plus low renin equals primary aldosteronism. So now hyperaldosteronism was our cause. To confirm this, we look at aldosteronism and renin ratio. Right. So if there is blood pressure, if there is high blood pressure and low renin, this is primary aldosteronism. obviously. If the patient is normotensive, but there is high renin, then there is Waterman-Kitterman syndrome or diuretics, because all of these Waterman-Kitterman diuretics, they basically act the same way, right? Then, if there is hypertension plus high renin, then there is also obviously a renovascular disease, which means that there is some renal artery stenosis or reno, reno renohepatic syndrome, or anything wrong with the vasculatory system leading to the kidneys, right? So this makes it very clear. This puts everything into a box, right? Then you can do ABGs if etiology is still unclear to get a hint of alkalosis or acidosis. That could also narrow down your differentials. And for the last, you can get a 24-hour electrolyte, so that you could, this is basically a gold standard for detecting any genetic abnormalities such as Barterman or Bitterman syndrome. This is rarely needed, but I've just put it there for you to know. So this is an algorithm that you must know and understand. Take a look at it. You can pause the video and take a look at it. And this is all. So this is how you diagnose the etiology of hypokalemia by using this method, and the treatment remains the same.